So today is about therapeutic promises of neuromodulation, and that sounds promising. So let's see if we can fulfill this. Yeah, I'm pretty clean, so that's okay, I hope. This is an important topic because we all try to help people with headaches. They come to us for advice, for guidance, and we try to do our best, all of us. But sometimes we come up short. The things we have to offer, they don't work. So we need to discuss, as we're doing at this meeting, how can we improve this? What options do we have available? And some of the options we have available are actually, they're working quite well in most of the patients, but not all the time. And you are aware of these figures. You have heard it throughout this weekend, that the acute treatment we are offering our patients, it's effective often. Sometimes it takes too long to work. The pain doesn't go away. It doesn't solve the problem. The people with headache, they cannot make plans because we have inconsistent results. Sometimes the treatment might work, sometimes it doesn't. It's difficult to make plans ahead based on that. Headache comes back, even though you take your treatment as prescribed. And side effects, that's always a thing we need to discuss with the people that comes to us for advice. Same thing goes for prevention. If you have very frequent headaches, acute treatment may not be enough. You need to offer some preventive treatment, and that's good. Apart from the fact that in many cases, the treatment options we have available, they're not very good. They don't work, or they have too many side effects. So there's clearly a need for us, based on this, to expand our armamentarium. What can we offer our patients? So, the question is this therapeutic promise of neuromodulation. I mean, the need is clearly there. So, we don't have the solutions that the patients are asking for. So we need to come up with something with fewer side effects, something that may be used in addition to what we always give. This is something the patients, they have figured this out already. When they come to you for advice, they have often started on something else. So 50% of people with migraine, they actually use complementary alternative medicines. If we don't ask about it, we are not told. So we need to keep this in mind when we talk to people with headaches. Do you use anything else for your headaches? And they do. They should be able to talk to us about this. We should be able to advise about it. But they don't bring it up. So let's move ahead. This should be old news to you. After this weekend, you've heard it a lot, I think, that migraine is trigeminal vascular disorder. As you see this figure here, there are so many levels where we can actually, we have treatments that can work. It goes for drugs. But as you see, some of these treatment targets could also be available for neuromodulation. I'm going to go through some of the available treatments in a minute. But based on the idea that migraine is a system disorder like this, it should not surprise us that if we can somehow find an in to affect some of these structures, that could actually be a meaningful and beneficial way of treating migraine. I hope we are all in agreement so far. So how do we do that? Well, people are ingenious. So there's a recent review out where some of these different strategies are being reviewed. I suggest you all read it. It's a pretty good paper. So based on this, it's obvious that people have been working their way through ways of actually getting to the trigeminal vascular system. Somehow, when people are having an attack, how to stop it or even to prevent an attack. So let's go through some of these different techniques. We know from headache care that people with severe headache, cluster headache, for instance, and also migraines, they are treated with blockades of the greater occipital nerve. Now, that's one of the things that has been tested in the neuromodulation area as well. So there's a good study. It's not that recent, actually, but it's based on the idea if you can somehow target the greater occipital nerve, you have an in here to the trigeminal vascular system. That makes sense because there's a functional link, so that this is a meaningful way in. So these afferents, they can be targeted with the peripheral stimulation, and they somehow in here end up at the same central pain pathway. The idea is that this gate control theory. That way you can actually suppress the migraine pain. That makes sense from a theoretical point of view. So people set out to study this in a pretty good study, actually, some years ago. But it was randomized, it was double-blind and controlled. And that's the way we should do this. Just when we do drug treatments, we should be ambitious about how we study these techniques. It didn't work, though. So this improved our knowledge of, okay, maybe that's not where we want to put our money. On the other hand, it turned out that if you actually build in a stimulator, it turned out that many of these people actually needed surgical revisions and had adverse effects. So I think it's fair to say that occipital nerve stimulation is not a meaningful way to go about treating migraine attacks. That's what we learned from these studies. So let's instead focus on the treatments that are actually good enough to have received the official seal of approval, if FDA approved. If FDA likes it, it should be good. I think that's the thinking here. So the next one up, transcranial magnetic stimulation. It's this device up here, very elegant. That's also based on clinical studies to support that it makes sense, actually. If you can use this magnet stimulator, you can actually suppress cortical spreading depression. You heard about that earlier today, that's important when you talk about migraine with aura. And also, we know that if you use low-frequency stimulation, you can inhibit the cortex, and if you use high-frequency stimulation, you can activate the cortex. So it's an on-off switch we have here. Once again, this is based on an understanding of these network models of neuromodulators with GABA and, for instance, and the glutamatergic neurons. So, I mean, there's a meaningful science behind this, which is good when we want to explain this to our patients. So does it work? Well, this was tested, once again, in a high-quality trial. Randomized, double-blind, parallel group. We like this. This is high-quality studies. This is for acute treatment. Once again, pain-free response at 2 hours. This is what we aim for when we use triptans and other acute treatments. So this is a meaningful endpoint in a meaningful design. And it worked. The pain-free rates were higher if you used the stimulator than if you used it with a sham protocol. Therapeutic gain, 17%. What does that mean? It gives us a number needed to treat of about 6. So if you treat 6 attacks, 1 of them is going to be successful. This is more or less the same we see with triptan tablets. And that's what we offer people on a daily basis. So this works, and it's FDA approved. So here you are. This makes sense. And it's a very elegant apparatus. As you see, you just sit like this, and the pain goes away. What about using this for preventive treatment? The idea that you suppress cortical activity, you're able to prevent the next migraine attack. Well, this is a bit more complicated. They did a study, a spouse study, but there are no randomized control studies of this. There was an open-label, single-arm observational study where you'd use this device, 4 pulses twice daily, and also for each attack. Number of headache days was the endpoint, which is a meaningful endpoint, and it seemed to produce a reduction in the number of headache days. That's good. Once again, this is an open-label study, so we don't really know if these results will hold up. So it's not approved for preventive treatment. But there are other ways in. What about the trigeminal nerve? I mean, we talked about this as a main culprit for migraine. This is the key of the trigeminal vascular system. It's up here. Once again, you put it on where the terminal branches of the trigeminal nerve are available. You can reach them easily. This is also where the pain is located. This makes sense. Once again, if you are able to inhibit nociceptive firing, the idea is this should be effective for managing a migraine attack. And it's a beautiful device. I mean, this is really elegant, I think. So does it work? Well, this was tested in a randomized control study, as you should, as for acute treatment. Once again, double-blind, randomized, sham-controlled study. Devices, the design is sound. Primary outcome, mean change in pain intensity 1 hour compared to baseline. We just talked before about the 2-hour endpoint. I think this is interesting when you look at the results here. Because after 1 hour, yes, this was effective. So that's good. But once again, if you look at the guidelines for how we want to do good studies in the treatment of migraine, the endpoint should be pain freedom at 2 hours. That's what we get when we looked at the triptan trials and all the other acute treatment trials. So what about this beautiful device? Did it work? Well, it did not. There was no difference in pain-free subjects after 2 hours. So based on the endpoint that we use for all other acute treatment trials, this didn't work. So what happened? Well, it's still FDA approved for acute treatment. And that should make you wonder, I think. What else? Yeah, the vagus nerve, also interesting. Once again, the idea is that the central projections are shared with the trigeminal vascular system. This is a way in to affect the trigeminal vascular system. This is what we want when we want to treat migraines. Especially because there are many of these C fibers for the pain transmission. We know from preclinical studies, from imaging studies, that if you stimulate the vagal nerve, you can actually see deactivation of the spinal trigeminal nucleus. So the idea is sound. We have preclinical studies to say this might actually work. So did it? This is a premium trial. This is for preventive treatment of migraine. This is a device, looks like an iPhone, which is nice. The study design is good. Double-blind, randomized treatment, the way it should be. This is a pretty big study, which is also very positive. You use this 3 times a day. You have to sit down, apply it to the vagus nerve. Yeah, well, it didn't really work, unfortunately, but the study was good. Yeah, so this doesn't work for migraine prevention. What about if you use it for acute treatment? Well, same device, different paradigm. It was also used in the randomized study here. Once again, double-blind, randomized, sham-controlled, the way we like it. Also a fairly big study. You used it within 20 minutes after pain onset. Primary endpoint, pain freedom after 2 hours. This is what we want. This is what we know from the triptan trials. This is what the International Headache Society recommends as a primary endpoint. Yeah, it worked well at 30 minutes, 60 minutes, but there was no difference at 2 hours. Oh, well, it's still approved by the FDA. Once again, based on a study that didn't really fulfill the endpoint that we normally expect from acute treatments, this device is FDA approved for acute treatment of migraines. What else? Well, what if you just jumble it all together? That's a new thing. If you try to take the trigeminal stimulator and combine it with an occipital stimulator, that must be good. Let's see. There's a study out, Relivion. The same thing, combined occipital and trigeminal neurostimulation. This beautiful device, it's a preprint. It's not out yet, but study is good, prospective, randomized, double-blind, sham-controlled trial. It's not that big of a study, which is too bad. But once again, change in mean baseline pain intensity based on score 1 hour after treatment. It was good after 30 minutes and also after 2 hours, 41% versus 20%. So it works. This gives you a therapeutic gain, 2 hours of approximately 20, which gives you a number needed to treat of 5. This is one study, not even peer-reviewed. There you go, approved by the FDA. So that's good. So there are many treatment options available, and they are all nifty to look at, and you can buy them anywhere you buy your iPhones. This one as well. So what if we look at all the data? Make a meta-analysis and a systematic review? Well, that has been done. And there's a number of studies out, of course. Once again, the conclusion here, based on these studies I've showed you and a few more, yeah, this seems interesting. Evidence for utility means, yeah, you can use it because it's not going to kill you probably. And in some select patient group, this makes sense because if you can't take any drugs, what are you going to do? Well, you need other options, and this is one. And as always, larger, well-conducted studies are necessary. And that's, I'm going to show in a minute, why that is absolutely true. We need bigger and better studies. Because if you look at the data, I mean, we've just been through a time where the CGRP antibodies are coming out based on large multi-center studies with thousands of patients. So let's look at the data based on that all of these recommendations are based on. These are the non-invasive neuromodulation studies. And it may be a bit difficult to read, but there are some of these things that are really worth noting. These are based on acute migraine treatments. And what I think is mostly interesting here is that if you look up number of blinded studies here, it's, well, some of them are blinded, but not all. Are some of these sham-controlled? Yes, some of them, but not all. Do all of these studies use a meaningful endpoint based on the International Headache Society recommendation? Well, they do not. Some of them don't, some of them actually do. But just imagine a pharmaceutical company trying to sell you or trying to get an approval of an acute treatment for migraine, and they come up with studies with 30 or 40 patients, unblinded, with endpoints they make up themselves. I mean, nobody is ever going to approve that. So this is a wild, wild west. If you have a device, you can come up with a study design you actually just make up on the spot, apparently. You don't have to spend much time enrolling patients. And then you come up with studies that can be included in a meta-analysis to say, yeah, this looks good. But the studies are mainly very bad, and I think we need to keep that in mind. So what about the preventive studies? That must be different. Well, it's not. These studies are, for most of them, small, as you see out here. You have studies with 60 or 50 patients, 14 patients, that's nothing. Are they blinded? No. Mostly they're not blinded. Do they use a meaningful endpoint? Yeah, some of them do. Once again, in a day and age where we have large studies made state-of-the-art based in the pharmaceutical world, to base clinical recommendation on studies like this is reckless, I think. But of course, there's always room for improvement. So what about, should we use these techniques? Well, there's a position statement out by the European Headache Federation that's 8 years old now, but it still stands, and it makes sense. Because if you don't have anything else, if you have a back up against the wall, of course you need to figure out something else. And this is where these treatments might actually come into play. Everything else has failed. The patient is unable to do anything else. This could be a way out, of course. This is not something that you should do in your clinic as a first treatment. This is something you should consider if everything else has failed. So you need to contact your headache center and ask, do you have a trial? Do you have any way of trying out these neuromodulation techniques on this patient where everything else has failed? Of course, it's always wise to use the non-invasive strategies rather than implanting devices. That goes without saying. The least invasive therapy should always be first line. And it would be very nice if you do a randomized control study, if you actually use a meaningful endpoint, please, because that's what we do in all other migraine treatments. I think the EFS recommendations is really trying to say, let's be ambitious about this. And we do that in all other fields in the migraine research and also in the migraine clinical reality. We should do that too. So European Headache Federation say, yeah, it's fine to use neuromodulation. You should use it if everything else doesn't work. Please include these patients in a clinical trial so we get the meaningful data out of this. And to make sure that, of course, don't use a device that have potential side effects. And I think that's difficult to disagree on. And this is a flowchart. This is how to go about it. And we actually have this, the patient journey here has to be rather long to end up down here before we consider neuromodulation. And that's also the current state of affairs based on the clinical recommendation, at least from the Danish Headache Society, and also based on in most other countries. So is this off the table? I don't think it is. Migraine is multifactorial. We looked at, you have had state-of-the-art lectures about the pathophysiology and how this, where does migraine come from, what to do about it. And there's a lot of talk about CGRP, but there's a world beyond CGRP. I know this is surprising to some, but there is. So if we consider the neurobiology of migraine, there are some other ways we can somehow affect the trigeminal vascular system to make sure that we get a treatment effect. So it makes sense to think neuromodulation in this whole wide range of treatment possibilities. And once again, why should one intervention be enough? Migraine is not a CGRP disorder. CGRP is part of the pathophysiology, but there's so much else at play here. So it makes sense to think in a broader sense. We should have treatments options available for all types of patients. And also, you can do normal, well-studied treatment and then add neuromodulation on top of that if you want to. That makes sense. In general, there are few side effects from neuromodulation treatment, which is positive. And the patients may actually like this. This is something they can do themselves. So if we involve the patients in this, they may actually be able to say, I like to treat my migraines without use of drugs, for instance. Okay, well, let's talk about neuromodulation then. Well, it's not all sugar and spice, because this costs money. And in Denmark, for instance, this is something you have to pay for yourself if you happen to suffer from migraine. So if you have a lot of money, that's good for you. You can go ahead and buy all of these devices. But this is not something that you can get reimbursed. And what we want when we look for good treatments and management options for migraine, we would like to have something available that everybody can benefit from. So as long as we keep this in the hands of those who can actually pay for it, it's going to be a select few who gain anything from this. And also, if we want to keep this in the healthcare sector, this is money we need to find somewhere. And based on the studies I've just showed you, I think we need to consider very carefully whether this is something we want to spend our money on. This may preclude access to effective treatment. If migraine is considered a disorder where you can just go down to the drugstore and buy whatever device they have on sale and then live with your migraine, people with migraine are going to get unsatisfactory treatment. We can do much better. So this is not a way of saying, yeah, you just figure out, try a device and see how it goes. Once again, we need to be ambitious about migraine treatment. It's not being ambitious to say you just figure it out yourself. The studies I've showed you are in general of very low quality. And the studies that are of good quality, I showed you some, they show that the treatment doesn't work. So if we have studies of low quality, we have low level of evidence. And I think that also reflects the day-to-day treatment landscape of today. We don't use neuromodulation very much in Denmark. If we get good studies to show that this is really effective, well, that's different. Blinding is difficult. Often at times it's used, we use these sham protocols are used, but blinding is in general difficult. If you put a device on your head, I mean, you're likely to know that you have it on. Once again, when we talk about quality of study, of evidence, these studies, there's great variation in the quality. Some are as good as the big pharmaceutical studies. Others are something cooked up in a basement somewhere. That's what it looks like. So now we should somehow reach an agreement. Is this something we want to go out and offer to our patients? Is this the new thing? Is this something that's really, really good? Something we're going to talk about for a long time that's going to keep us all happy and be with us? Or is it, this one? I think this discussion is wide open still. The data right now is not very good. So I think there's room for improvement. And once again, we need to be ambitious about this. We cannot base our recommendations on small studies. We need to ask the producers of these devices to say, if you want us to take this seriously, you have to set up large studies, good quality studies, and then we can talk about it. We may meet again at this conference like this and say, well, the good studies are out now, and this is really effective. Great, this is going to be part of what we do. Right now, I don't think we are ready for prime time with neuromodulation. And with that, I'm happy to discuss this with you. Thank you.
Thank you for your excellent presentation. And now, let's see, we have, I see, from Dr. Thompson, a question for you.
Thank you for a very interesting talk, Jakob. First of all, I would just like to comment that I actually watched The Phantom Menace as late as last night, and it actually gets better with time. Okay. So we could hope the same holds up for neuromodulation. I was wondering, your talk was mostly focused on the non-invasive neuromodulation, and I know for SPG modulation that doesn't hold much promise, I think. But do you think, are there any other invasive types of neuromodulation which could be promising in your opinion?
We know from the from studies in cluster headache that the SPG stimulation was actually effective in also based on good clinical studies, and these are also people where other options didn't really have any meaningful effect. So once again, we're way down in this flow chart of how do we manage this. If we have good non-invasive treatment options, that's obviously the way to go. And there are no good invasive studies based on migraine that I think we should follow up on. So I think if you look at the food chain, I think we should start out making sure that the non-invasive studies are done well and proper. And if they're good, then it makes sense to go on to say, are there any more draconian measures we should study, but also based on the same level of methodology and scrutiny that we expect from other treatments. And that's just not the landscape we see right now. So we have a way to go before we should get to that, I think.
Thank you.
And Jakob, we have also a question from the online audience that Christopher is asking whether you think deaf ear piercing is a form of neuromodulation for the vagus nerve.
I have many people with headaches that has tried this dive piercing, and I have looked up if there are any good studies based on this. There's not. So once again, we end up with case reports of people feeling strongly about one treatment or the other. And once again, if we ask people to actually get a piercing and use that as a treatment for their migraines, I think we need to have better studies to support that notion. Otherwise, I'll be happy to offer them a prescription for a triptan or anything else that might work. But of course, I mean, patient preference is very important here. And this is something they have often, at least the people that I advise, they've often done this before they come see me. So I wasn't asked what I think about it. So that's fine, I mean, but they come to me because it doesn't work. Because if it solved their problem, they'd be happy out in the sun today instead of talking to me. So I think if we are to recommend treatments for the people to seek our advice, I think we need good studies, and we don't have that for these dive piercings. But if you think piercing looks good, I mean that's you can go ahead and get one, but the data is not there to support it.
So, because I'm not very familiar actually with this specific piercing, is there actual research backing it up, or I mean, how did it end up?
It's the same as with the others. There are a few case reports. Mm-hmm. It's a small piercing you throw in here in the tragus. Mm-hmm. It looks very nice and it's beautiful if you like piercings. Mm-hmm. But the data is it's not there.
Okay, thank you. And now from the audience here, a question?
Yes, hello, I am Rune from the Danish Headache Center. I would just like to ask regarding the blinding, is there any different skin sensation from the sham group in these neurostimulation studies? And also one other question, in humans are there actually neurophysiological measurements that it does inhibit and activate the trigeminal nerves?
There are some of the fMRI studies that showed based on some of the studies that I showed you, you can see a deactivation in the spinal trigeminal nucleus. But we don't really put electrodes in, so these are based on blood flow studies, so we don't know. The blinding is always difficult here, because if you get an impulse of sorts, you're likely to know that's what you got. And at least some of the good quality studies, they were asked about the quality of the blinding. And I think the big Lipton study from 2010, that's actually turned out to be pretty good. And that's also what the FDA approved for acute treatment of migraine. But in many of the other studies, the quality of the studies is fairly low. And some are often even single-arm studies. So people know what they've been treated with. But I think This discussion makes sense if we are looking at large studies, 500, 800 people, the ones we know from the pharmaceutical studies. I don't think it's that interesting to talk about these very low quality small studies, whether the blinding works or not, because it makes no sense. I mean, we need better evidence, and better evidence is based on size and as better sample size. And very few of the studies have actually gone through the work of actually providing that. So the evidence is still lacking. And once it's good, we can talk about the finer details, but we're not there yet.
Okay, thank you.
Thank you, Jakob, for your presentation. How can you explain that those with a good quality in terms of the power and also design, they failed in the primary endpoint, and still many of our colleagues recommend using these devices, and how it's possible that FDA approves these devices? Do you have any explanation for the devices? Is something special about devices compared to pharmacological agents? What is it?
That's a really good question. I think the approval process of pharmacological treatment is different from device treatments. What I think the wording used is it's FDA cleared. That's what they say. It's analog to the European, the CE mark. And that mainly means that this is not going to kill you. It's not dangerous, but it's not in any way. It hasn't been scrutinized the way we do with pharmacological treatments. So I think to get a clearance by FDA may not be that difficult, but I think like I said before, I think we should be ambitious about this. So the fact that anybody can come with a device and get a CE mark or an FDA clearance, I think that's maybe perceived as a way of recommendation for using this, but the data quality is not there to support that. So I think if our colleagues recommend using these, I think, yeah, well, like I said, if we need a large spectrum of treatment modalities. Some people with headaches may have severe side effects, so they may be averse to drugs. So this is a way of at least getting a alliance to say, okay, let's try something. And if it doesn't work, then we can take the next steps. So I think that could be a way of explaining it. If people are sent out of the office with this as the only treatment and nothing else, I think they're being, I think good options are being withheld from them, and I think that's a shame.
We have another question from the audience here.
Thank you, Anne from the patient organization again. I think it's important that we discriminate between which the treatments that the doctors and the authorities approve and recommend and have tested, and it's something we can trust. If people get an hour's respite from their migraine by sitting with one of these gadgets now and again, I think that's a good hour. And my suggestion is that the doctors pretty much keep their fingers off. Because as soon as you go in and say they're no good, the placebo effect wanes, it goes away. If you find that one is better than the others and it's only marginal or whatever you can get to, that is a problem too. So my suggestion is that you keep away from it and treat it in the same way as you would do with Himalaya salt or the piercing in the ear or whatever. Other things that have a marginal effect, a placebo effect, probably a good placebo effect in those who are liable to respond to placebo in the big way. Instead of trying to prove that it's no good.
Yeah.
Thank you.
Yeah. I think that's a valid point. However, I also think, and I said that before, I think we should be ambitious about migraine treatment. So if people come to us, to the doctors, and ask for advice, is this likely to help me? Is this beneficial? I will feel very strange about saying, well, I could tell you about how this works, but I won't, because you need the placebo effect. I will feel much better saying, well, we have some treatment that has been studied. Most of them are studied in a way that makes it unable for us to deduce anything about the effect, but a few of them might actually be. So it means that the producers and the purveyors of these devices, if they are ambitious about migraine treatment, if they make good studies, large, high-quality studies that actually show that this treatment is effective, I'll be more than happy to tell all the people seeking my advice, this one has been tested in a meaningful way. This is likely to help you. The rest, I don't know. If you ask me about it, should I try? I say, well, I don't care. I mean, do you have money to spend? Do you have 5,000 kroners lying around you want to buy this device for? Then go ahead. But most people, they will say, this 5,000 crowns, I might actually be able to use that for something more meaningful than buying some device or the other, because it's never going to end. This is an endless stream of devices that you can always pick up on Amazon or what do I know. So I think as a healthcare professional, I will be ambitious about migraine treatment. So if people come to me and ask for it, I'll be happy to share my opinion based on good clinical data. But I agree with you, of course, that people might be disappointed and say, well, I thought it might work for me. I say, we don't know, but the data seems to suggest this is unlikely to be of any meaningful effect to you. So that's the way I'll go about it. But I understand your point completely.
And just to comment on that, Jakob, it makes me wonder whether their over-the-counter availability limits somehow this ambition for more rigorous trials and making it more apparent whether they work or not. Mm. So it's very complicated compared to other prescription medication.
That's true. I mean, the hurdles you have to pass to get a device on the market are so much lower than for pharmaceutical treatments, which is good because if they are available, you can go buy them if you have the money to spare. So in many ways, it's good that you don't need a doctor's approval, but that also means that you are likely to just having to choose from a wide variety of devices that may not be of any effect at all. And like I said, I think we need to be ambitious. So let's talk about what works and what doesn't. Mm-hmm. And I think that's why people come to us. They come for advice and say, is this likely to work for me or not? And if I don't have the data, I have a hard time really giving good advice. So that's why I think ambitious studies is going to help me and everybody else in this room to care for our patients.
Yes, I agree. And now we have a question from the online audience from Bursu Polat that is maybe in a more designing of trial question about how many patients would you say you need for a neuromodulation study to show its effectiveness and safety?
That's also a really good study. I think we're back to really basic study design and say, what is the likely effect size you're looking at? And in many ways, I think it would make sense to seek inspiration in the pharmaceutical studies, the drug studies that are based on hundreds of patients, because that gives you a sample size that makes sure that if there's effect, you're going to find it. You may even pick up side effects. So I think these studies based on 20, 30, 40 patients, I think they're very good as proof of concept studies. But if you want to get a drug treatment approved, you need at least 2 large phase 3 studies. And we're talking about several hundred patients here. And I do know that's a hard hurdle to pass. But once again, if you want to make everybody get behind these therapies, you need that kind of studies. So I would say the effect size that we have looked at from the studies I showed you today would suggest that if you want to do a good study, I mean, at least a couple of hundred patients in each group, and that's probably even on the non-ambitious side. So more than that, this is a big undertaking. But once again, if you claim this is going to help people with migraines, you should be ambitious about it.
Yes. And we have Dr. Dahl wanting to ask a question.
Thank you for an excellent talk, Dr. Hansen. I completely agree with you that there's limited data on the use of neuromodulation devices, but the same can be said for a lot of non-pharmacological approaches that we use in clinical practice. Would you say that we should avoid all therapies that do not have completely solid data, or are there some patient populations where they may be beneficial, for instance, in terms of pregnancy or other cases where pharmacological treatment is contraindicated?
I think that's really an excellent question, because what do we do in these cases where standard treatment doesn't give us the benefit we aim for? And based on this European Headache Federation consensus statement, if normal treatment is not available or doesn't work, yeah, I mean, by all means, consider adding this as a possibility, preferably in a randomized control trial, because these N of 1 studies doesn't give us any meaningful knowledge about what is working. So yeah, I think in some cases this may be interesting, of course, because after all, people come to us for advice and say, nothing else helps. What should I do? But what we should not do is just go ahead and recommend things that we know from the studies available is unlikely to be of effect. So I think in some select cases, yes, this may be something we should talk about, with all the caveats I mentioned, that we don't know if it works, we don't know any safety for these studies because the studies are small. So it's going to be very few and select cases, I think.
And do you have any idea, Jakob, if over Europe or the US, these devices are covered by the basic healthcare insurance, or everywhere it's just the patients have to just buy them?
I think I've read in America, some of these of the producers here, they have set up programs where you can apply for it. I think in most cases this is something you need to pay for yourself. If you have, it depends on your level of insurance. If you're privately insured, some people might be covered. But once again, back to the part about being ambitious, when we talk about good migraine treatment, we want something that's available to everybody, not just the few people who have to have a few gold bars lying around. So I think in most cases this is going to lead to expenses, and if there are other things that might work better. You should try before setting out on this. That's my opinion.
And we have another question from online, where Adele is asking if there are studies on pressure point devices on the side of the nose, for example.
Yeah, good question. I don't even know. That's I'm unable to answer that. I choose some of these for presentations, some of the interventions that has been studied in several models. So I don't know about that. Most of the studies that is about pressure points that I've looked at before. There's also a pressure point thing about the thumb or something like that. I mean, it's based on mainly very small N of 1 studies. I cannot answer that question, but of course, it's based on what I started out by saying. If it's somehow an into the trigeminal vascular system, and it is, yeah, you can argue from the mechanistic point of view that this could be a meaningful way of trying to get an in to see if you can affect it, but whether it works or not, I can't say.
Yes, and I think then we get maybe in a very dangerous field where we try from just individual cases to try and propose strategies to the patients, and that's maybe not
but
the
that's
right way.
That's how all therapy started out. So if somebody can come up with a device and say, this is safe, let's study, yes, let's study it, and let the data show if this is the way to go. But based on the idea that you want to affect the trigeminal nerve, yeah, sure, that might work. We just don't know yet.
Okay, so if there are no questions from the online audience or from the room, then I think we're done. And thank you very much for the nice conversation.
Thank you.